Thank you, sir. I'm Dr. Asheesh Tandon from the Advanced Neurosurgery Brain and Spine Center working at Jabalpur, India. Uh, I would like to present my appreciation to all the members of MISAB for allowing me to share this technique today. And though it is not absolutely MIS, but still I feel that inserting this cage, the technique of inserting the cage is a little invasive, minimally invasive for the roots. So I'll just start with the case, though I have lined up few cases together, which I'll quickly show. So here is a girl who's 10 years old, progressively increasing hump in the dorsolumbar region. She has developed weakness with a power of 4/5 in her lower limbs and a Cobb's angle of 60 degrees. This was her MRI on presentation. And so when such a case comes, especially here where you have to do 2 levels and a large cage is required, so the questions that were running through my mind were whether I go purely anterior, posterior, or combined, and how do I preserve the roots in case if I go in for a totally posterior approach. So we all know the challenges of placing a long cage, especially if we have the roots. So while I was thinking and discussing, I came across this paper by Travis Hunt and his team. This has been published in Journal of Neurosurgery Spine, and I would quickly share the steps. So routine prone position, GA with neuromonitoring, a standard posterior exposure, and thereafter a transpedicular corpectomy, either unilateral or bilateral, whichever way you are comfortable. And then obviously we preserve the roots. So in essence, the steps include that they tie threads or sutures or tapes to the expandable cage. And then what they do is they start inserting the cage between the roots. And then they push the cage inside. And finally, what they do is they bring one of the tapes out from below the root. And thereafter, they have a good snugly held cage. So I'll just quickly share a short video here. It's just about a minute or so. Here, after we have inserted the pedicle screws, and then we are doing an anterior unilateral decompression. Here, yeah. So past the cage has been tied with the. I use Vicryl because it sort of I can just cut the Vicryl and leave the remnant there. And so once I have pushed the cage inside, then I can sort of pull the thread from below and the cage can be pushed in and then sort of impacted into the right position. So this was the pre-op, and this I could achieve post-operatively. So I'll just quickly go through another 2-3 cases, very short. This was 2-level destruction with dorsolumbar pain. This was the MRI of the gentleman. And again, this we introduced an expandable cage. Sort of we have tried to shift towards expandable cage. Another lady in 3rd decade, neurologically, she was well preserved with pain spreading to her posterior aspect of the thigh. This was her destruction in X-rays and CT scans. So we again took a posterior approach and we finally fixed her in this position. Another, I'll skip this. Yeah, the final case, a 28-year-old female with a single level destruction. This was her axial CT, MRI, and this was finally what we achieved. There's another modification of the technique which has been also published in Spine, and this was published in 2008, where the author has used bilateral approach. So the thread or the suture comes out from the opposite side as well. So according to him, the hold is much better. So to quickly conclude, large cages can be accommodated while we preserve the roots, and a better control can be achieved while impacting the cage. Once again, extremely thankful to all the members for this opportunity. Thank you.